Welcome to the Deep Dive, where we try to cut through the complexity and really get to the core insights. Today, we're diving into a pretty fascinating area of medicine, myeloproliferative neoplasms. You might hear them called MPNs. Now, these aren't your everyday blood disorders. We're talking about conditions where the body's own blood cell factory, the bone marrow, basically goes into overdrive. It starts making too many of certain types of cells. So we're going to unpack how these conditions can subtly show up, the really clever ways doctors diagnose them, and why understanding their specific pathways isn't just academic, it's actually vital for treatment.
That's exactly right. Think of MPNs as a family of disorders. The bone marrow, which is essentially our blood cell production center, it starts producing way too many red blood cells or white blood cells or platelets. And they can be pretty tricky because the symptoms often overlap quite a bit. And what's really interesting, actually, is how one type can sometimes, over time, even transform into another. So for this deep dive, we'll really focus on three key members of this family: polycythemia vera, or PV, essential thrombocytosis, ET, and primary myelofibrosis, which is PMF. Getting a handle on these three really helps you grasp the bigger picture of, well, blood cancers and related conditions.
Okay, so let's start with polycythemia vera, PV. I've heard it described as having too much blood, which is almost the exact opposite of something like pancytopenia, where you see a drop in all blood cells, right?
Precisely.
So when we look at PV, what are some of the signs that really jump out?
Well, okay, beyond the sort of general things like fatigue or maybe headaches, patients often have an enlarged spleen. We call that splenomegaly. But one of the most distinctive symptoms, and it often really baffles patients, is something called aquagenic pruritus. It's this intense itchiness, but specifically triggered by contact with water, like after a shower or bath.
Wow.
Yeah, it's thought to be caused by certain white blood cells, basophils releasing histamine.
That aquagenic pruritus, it sounds incredibly uncomfortable and really specific.
Yeah.
Are there other sort of unusual or key physical signs we should know about?
Oh, absolutely. Another one that can be a real hallmark is erythromelalgia. This is a burning pain, usually in the feet or hands, and it often comes with skin color changes like redness or sometimes a bluish tint. You might also see something called facial plethora. That's sort of a ruddy, reddish-blue complexion. And here's the surprising thing. Even though they're making too many red cells, patients can actually feel really fatigued and sometimes even develop microcytic anemia. That's where the red blood cells are smaller than usual.
Wait, how does that happen? Anemia with too many cells?
Yeah, it seems counterintuitive, right? But the body is working so hard, churning out all these extra red cells, that it burns through its iron stores incredibly quickly. So you end up iron deficient. Oh, and gouty arthritis can pop up too because of the high turnover of red blood cells.
That's just fascinating. A condition of too much leading to things like anemia and fatigue. Okay, so if someone comes in with these kinds of symptoms, how do doctors actually pin down a PV diagnosis? You mentioned something about a game changer?
Yeah, so the first clues are usually those high hemoglobin and hematocrit levels in the blood test showing that too much blood picture. But the real breakthrough, the diagnostic game changer you're asking about, that came with discovering the JA2V617F gene mutation.
Ah, JAK2.
Exactly. Over 97% of PV cases have this specific genetic typo. It's become this incredibly crucial, highly specific marker. It really shifted diagnosis, from just looking at symptoms to being able to identify it at a molecular level. And that understanding now directly guides targeted treatments, which is huge. We also usually see low levels of erythropoietin, or EPO. That's the hormone that normally tells the bone marrow to make red cells. Low EPO helps distinguish PV from other causes of high red cells, like, say, chronic low oxygen from lung disease, or living at high altitude, or even certain tumors that make EPO. But ultimately, a bone marrow biopsy is done to confirm it and see what's going on inside the marrow itself.
Right. And if this overproduction isn't managed properly, what are the main risks down the road?
Well, if it's left untreated, PV can cause some really serious problems. The biggest one is probably dangerous blood clots, thrombosis, either in arteries or veins. It can also, over time, progress to myelofibrosis, where bone marrow gets scarred up. Or in some cases, unfortunately, it can even develop into acute leukemia.
Okay, that definitely highlights why managing it is so important. So how do we typically treat PV? What are the main approaches?
The mainstays are, first, phlebotomy. That's basically therapeutic bloodletting.
Like in the old days?
Sort of, but much more controlled. We periodically remove blood to get the hematocrit level down to a safer range. The goal is usually less than 45% in men and less than 42% in women. And then for patients who are at a higher risk of clotting, we often use medications like hydroxyurea. There's also a drug called ruxolitinib, which can be really effective for shrinking that enlarged spleen and helping with other systemic symptoms like fatigue or itching.
Okay, so from too many red blood cells in PV, let's shift gears. Let's talk about another MPN, essential thrombocytosis, or ET. Here, the issue is mainly platelets, right?
Exactly. With ET, the defining feature is a persistently high platelet count, usually over 450,000 per cubic millimeter. And what's really fascinating here is the kind of paradox you see. Some patients might have no symptoms at all, or they might experience what we call vasomotor symptoms, things related to blood vessel changes like headaches, dizziness, maybe visual disturbances. But here's the really counterintuitive part. Despite having too many platelets, patients can actually have problems with both thrombosis, dangerous clotting, and hemorrhage, or bleeding.
Both. How does that work?
Well, the bleeding isn't usually because there are too few platelets, but because the extremely high number of platelets don't always function properly. They're dysfunctional. Oh, and erythromelalgia, that burning pain in the hands or feet we talked about with PV, that can show up in ET too.
So way too many platelets, but they might not work right, leading to both clots and bleeding.
Yeah.
That really does challenge your basic understanding of how blood works. How do you tell ET apart from, say, just a high platelet count due to an infection or something?
That's a key point. For diagnosis, we need to see that persistently high platelet count, and then we have to carefully rule out what we call reactive causes. Things like infection, inflammation, iron deficiency. Those can all temporarily push platelet counts up. And what's really interesting is the genetic link again. About half of ET patients, maybe 50–60%, also have that same JAK2 V617F mutation we saw in PV.
Really? The same one?
Yep. And if the JAK2 test is negative, we then look for mutations in another gene called CALR. That accounts for a good chunk of the remaining cases. There's also MPL mutations, but JAK2 and CALR are the main ones.
Huh. It's so intriguing that the same JK2 mutation pops up in both PV and ET. Does that tell us something about where these conditions start? Maybe a shared origin?
It absolutely does. It strongly suggests that the problem starts way back, likely at the level of the hematopoietic stem cell in the bone marrow. It points to a disruption in a common signaling pathway, even if the end result, too many red cells versus too many platelets, looks different. And understanding this shared biology is really key for developing treatments that target these specific pathways across different MPNs. Now, thinking about complications specific to ET, around 20% of patients might develop something called acquired von Willebrand disease.
Acquired, like they weren't born with it.
Exactly. It's a bleeding disorder that develops because the huge number of platelets had to kind of mop up the von Willebrand factor protein from the blood. And that can complicate things, especially regarding the use of aspirin.
Right, that's a really important consideration. So given all these complexities, the clotting risk, the bleeding risk, the potential for acquired VWD, how is ET typically managed?
Well, for many patients, especially lower risk ones, low-dose aspirin is often used. It helps manage those vasomotor symptoms like erythromelalgia and can reduce clotting risk, provided the platelet count isn't too high and there's no significant bleeding issue like acquired VWD. But for patients who are considered higher risk, maybe they're older, say over 60, or their platelet count is very high, like over 1 million, or they've already had a clot, then we typically use medications to lower the platelet count. Hydroxyurea is very commonly used here. And studies have shown it significantly cuts down the risk of clots. And interestingly, that benefit seems to be partly independent of just lowering the platelet number itself.
Okay, so we've covered too many red cells, too many platelets. Now let's talk about what happens when the factory itself, the bone marrow, undergoes a really drastic change. What happens when it essentially starts turning into scar tissue? That's myelofibrosis, right? Which can sometimes develop from PV or just appear on its own as primary myelofibrosis, PMF. Tell us about that.
Right. Myelofibrosis, or PMF, is defined by that buildup of scar tissue fibrosis within the bone marrow. As this fibrous tissue kind of clogs up the marrow, the normal blood cell production machinery starts to fail. And because the main factory is failing, the body tries to compensate. It starts trying to make blood cells in other places, particularly the spleen and sometimes the liver. This is called extramedullary hematopoiesis, and it often leads to the spleen becoming massively enlarged, what we call massive splenomegaly.
Wow, so the spleen really balloons up trying to take over.
It really can, yes. And patients often develop significant anemia, typically normocytic, meaning the red cells are normal size, but there just aren't enough of them. And if you look at their blood under a microscope, you see some characteristic things like teardrop cells, red cells shaped like teardrops, and also immature blood cells, both white cells and red cells, that have spilled out of the marrow prematurely. Symptom-wise, some might be asymptomatic initially, but severe fatigue, fevers, night sweats, weight loss, those constitutional symptoms are very common. And while initially white cell and platelet counts might actually be high, as the fibrosis gets worse, they often drop, leading to leukopenia and thrombocytopenia.
So the bone marrow is essentially shutting down production, forcing other organs to try and pick up the slack, but not very effectively. How do you diagnose this, especially if the marrow itself is the problem? I imagine getting a sample is tough.
You hit the nail on the head. Often when doctors try to do a bone marrow aspirate, where they try to suck out some liquid marrow, they get what's called a dry tap.
The dry tap.
Yeah, basically they can't draw out much, if any, liquid marrow because it's so packed with fibrous tissue. So the diagnosis almost always requires a bone marrow biopsy where they take a small core sample of the bone itself, including the marrow within. That lets them directly see the fibrosis under the microscope and rule out other things. And if it's suspected to be post-polycythemia vera myelofibrosis, meaning it developed from pre-existing PV, then you need that history of PV. Plus confirmation of increased fibrosis in the biopsy, and usually at least two other things, like worsening anemia, maybe the patient doesn't need phlebotomy anymore, the spleen is getting bigger, or those constitutional symptoms are showing up.
That really paints a picture of how these internal cellular processes can just radically change the whole structure and function of vital organs, like the bone marrow and spleen. It really makes you wonder how the body even tries to cope with such profound shifts.
Okay, so we've explored PV, ET, and PMF, their unique features, how they're diagnosed, how they can evolve. But how do these specific MPNs fit into the bigger landscape of blood disorders, hematology and oncology more broadly? What's the bigger picture connection here?
Right. Well, if we sort of zoom out and connect this to the bigger picture, you start seeing common threads. Many of these conditions share symptoms, like different kinds of anemia, as we touched on, or they share common complications, like that risk of blood clots. But a really critical connection for MPNs, especially PV and ET, is their potential, unfortunately, to transform over time into more aggressive conditions. Specifically, they can progress to acute myeloid leukemia, AML, or to myelodysplastic syndrome, MDS.
MDS.
Yes, myelodysplastic syndrome. And developing myelofibrosis itself, or AML, are probably the most significant long-term complications we worry about with PV and ET. So a condition that might have started relatively slowly can actually turn into something much more serious, like leukemia. Can you tell us a bit more about MDS and AML? How do they fit in?
Sure. MDS, myelodysplastic syndrome, is really characterized by dysplasia. That means the blood cells developing in the bone marrow are abnormal. They're dysfunctional. You see this abnormality in one or more of the cell lines, red cells, white cells, or platelets when you look at the blood and marrow. And this often leads to low blood counts or cytopenias like anemia, low white cells, low platelets. MDS itself is considered a pre-leukemic condition because it has a significant risk of progressing to AML. Now, acute myeloid leukemia, AML, is a full-blown cancer of the myeloid line of blood cells. It often presents quite acutely with symptoms like easy bruising, bleeding, infections due to low white cells, fevers, and just profound fatigue. Microscopically, one distinctive feature can be hour rods. These are sort of needle-like structures inside the leukemic white blood cells. And sometimes AML can present as an emergency called leukostasis, where the white blood cell count is extremely high, making the blood thick and sluggish, which needs immediate treatment like chemotherapy or leukapheresis to quickly lower the count.
Okay, so AML is a potential progression. How does that relate to something like chronic myeloid leukemia, CML? Is that related to?
That's a good question. CML is also a type of leukemia involving uncontrolled growth of myeloid cells, and it often causes high white counts and an enlarged spleen, similar in some ways to MPNs. However, CML is biologically distinct. It's specifically defined by the presence of the Philadelphia chromosome, which is a specific genetic abnormality, a fusion gene called BCR-ABL. And crucially, CML is treated very differently, typically with targeted drugs called tyrosine kinase inhibitors, which have revolutionized its management. So while it involves myeloid cells, it's not usually grouped directly with the classic MPNs like PV, ET, and PMF.
Got it. And you mentioned earlier that anemia and clotting are common threads. We talked about the iron deficiency in PV. How do doctors sort through all the different types of anemia that might show up in these or other blood disorders?
Yeah, that's absolutely crucial because the treatment depends entirely on the cause. Anemia is just a symptom, really. So for example, we talked about iron deficiency anemia, IDA that gives you microcytic small red cells, and the lab tests show low iron, low ferritin, but high total iron binding capacity, or TIBC. Then you have conditions like thalassemia, which also cause microcytic anemia, but in that case, iron levels are usually normal or even high. Diagnosis there relies on tests like hemoglobin electrophoresis or DNA studies. Then there's macrocytic anemia with large red cells. That often points towards vitamin B12 or folate deficiency. B12 deficiency is particularly important to catch because it can cause neurological problems, sometimes even before the anemia or macrocytosis is obvious. We often need specific tests like methylmalonic acid levels to diagnose it. And then you have things like aplastic anemia, which is different again. There, the problem is the bone marrow just isn't producing enough of any cells, so you get pancytopenia, low counts of everything, and the marrow itself looks hypocellular, very empty under the microscope. That's different from MDS, where the marrow is usually cellular, but the cells are abnormal.
Okay, that clarifies the anemia picture a bit. What about the other side, clotting and bleeding? We discussed the paradox in ET, but what other major clotting or bleeding issues might come up in this context?
Right, so thrombosis, clotting is a big risk in MPNs, as we said. But doctors also have to be aware of other things. For example, heparin-induced thrombocytopenia, or HIT. This is a really serious immune reaction to heparin, an anticoagulant. Paradoxically, HIT causes low platelets, but dramatically increases the risk of clotting. It's a medical emergency requiring stopping heparin immediately and switching to a different anticoagulant.
Wow, low platelets causing clots.
Exactly, it's immune-mediated. Then on the bleeding side, you have inherited disorders like von Willebrand disease, VWD, which is the most common inherited bleeding disorder. It typically causes mucocutaneous bleeding nosebleeds, heavy periods, easy bruising, and sometimes affects a clotting test called the APTT. It's treated with things like desmopressin or specific VWF concentrates. And another important one is immune thrombocytopenic purpura, or ITP. Here, the immune system mistakenly attacks and destroys platelets. So you get isolated low platelets, often presenting with bruising or pinpoint bleeds called petechiae. Management often starts with steroids, and for severe or persistent cases, sometimes splenectomy, removing the spleen is considered.
It really underscores how incredibly complex and interconnected the whole blood system is.
Yeah.
And finally, just touching back on treatments for these conditions, especially the more serious ones, it's also important to keep in mind the potential side effects of the therapies themselves, right?
Yeah. Oh, absolutely. That's a huge part of managing any of these conditions, especially cancers. Understanding the potential toxicities of treatments is critical. For example, certain chemotherapy drugs called anthracyclines, doxorubicin is a common one, are known to have potential cardiotoxicity, meaning they can damage the heart muscle, sometimes years later. Another chemo drug, bluonmycin, can cause pulmonary fibrosis, which is scarring in the lungs. And radiation therapy, while obviously very important in many settings, carries long-term risks too, like potentially causing secondary cancers in the radiated field years down the line, or causing dysfunction in organs that receive radiation. So managing the disease always involves balancing the benefits of treatment against these potential short-term and long-term side effects. It's a constant calculation.
So we've really taken a deep dive today into myeloproliferative neoplasms, PV, ET, PMF, getting into their unique features, those diagnostic game changers like JAK2 and how they fit into the wider world of hematology. It's really a testament to the incredibly intricate and sometimes pretty surprising balance within our own bodies. And this journey, I think, really shows that understanding things right down to the genetic level, like the JAK2 or CALR mutations, it's not just about getting the diagnosis right anymore. It has fundamentally changed how we approach these diseases. It allows for much more targeted treatments, offering a more precise way to fight them.
Absolutely. And that level of detailed understanding, right down to specific mutations and the signaling pathways they mess up.
Yeah.
It's truly transforming how we tackle what once seemed like insurmountable medical challenges. It really makes you wonder, doesn't it? What other complex diseases might be next? What other conditions might soon start giving up their secrets because of this kind of precise molecular inquiry? And how is that going to continue to change the future of medicine, really, for all of us?
A really important question to ponder. Until next time, keep digging into the fascinating world around you.